Okay, the request of this patient, I wanted to give a high-level overview of his current case. So he is a 17-year-old competitive high school basketball athlete that has had 18 months or longer worth of patella tendinopathy. I'm only just new to his case. He transferred care to me in the last 4 to 6 weeks, and today's October 24th, so it was at the beginning of September, first or second week of 2023. So I conducted a strength test on one of the first evals, or one of the first sessions, and here are his results. So just giving a high level overview. So you can see overall symmetry is actually quite impeccable. So within 2, if not 6%, despite the persistent disability that he's had on the involved limb. The one thing that is of note, right, that stands out a little bit is maybe weakness of posterior chain on that involved side, and so this has been important regiment within the strength programming that we've incorporated. But I do want to take a moment and highlight the fact that one, that he's slightly superior on the involved side, and two, strength relative to body mass is off the chart. So we would expect an individual of his age to be producing anywhere between 86% and 115% of his body weight, and he's producing 120 plus percent at 60 degrees per second bilaterally, which is quite exceptional. Again, what we can see is that the quadriceps to hamstring ratio is off, however, right? We would want this to be substantially higher. Right now he's at 37 and 46% hamstring to quadriceps. So posterior chain work is a necessity bilaterally, but impressively strong relative to body weight. Additionally, when we look at some of the more fine-tuning results, beyond just peak torque, specifically rate of force development, without getting too far into it, this is the amount of force that he's producing within 20 to 80% of his MBIC. So just for context, a number of 3 is good, a number of 4 is great, and bilaterally he's at 6.8 relative to body weight, and he's producing a lot of force, specifically over 170 and over 180 foot-pounds per second, within, like, essentially, it's, or not even with per second, it's like within 20 milliseconds. And his limb symmetry here is also quite high, 86 and 84% respectively. So there could be further improvement to be had there, in regards to his 100 and 200 milliseconds, but he's actually even superior here slightly on his involved side at 104%, comparable to what we saw with the peak torque. So, like, strength of the quadriceps and rate of force development, which is commonly touted as being something that is of noteworthy when dealing with these chronic pathologies and chronic tendinopathies. For the duration and the chronicity of this condition, strength is really not his issue. It's a matter of structural reloading of the tendon that is otherwise needed. And so the plan of attack is as follows. So specifically, we've gone through activity modification. So I've had him work specifically and solely on basketball skills training over the next 8 weeks. So between September 1 and December 1, the meat and potatoes, the high stake games come into play in early to mid December, according to him, even though the season starts in mid November, and they're already starting to ramp up. So what we want to do is, it seems as though the activities that specifically bring on his pain are those that are ballistic nature, specifically a lot of jumping and a lot of cutting. However, he can run free without any puffiness and or implications of pain during and thereafter. So that's within the tissue's capacity. And so what my goal is to offload him from the provocative uh, skill or movements and or activities whilst still building the physiological capacities that are necessary for him to hit the ground running in December. So we're working on high intensity strength, particularly isometrics, but I'll speak to power and speed in a linear fashion because it's particularly the cutting movements and the in the open environment that seem to really insult the patella tendon and cause his not only his pain but also the subsequent puffiness and swelling or inflammatory response. We've been also microdosing ballistic movements so that we maintain that high rate of force development that we saw in the initial testing. We are going through a running progression as necessary for general preconditioning and as a necessary element and aspect of the sport, and with strategic means of doing a walk jog progression with higher intensity boluses using a slight incline. Thus, we're avoiding the braking forces or diminishing those. And then we're also doing other forms of non impact cardiovascular conditioning, such as sled pushes and uh, assault bikes, as well as dead treadmill pushes. These are some examples of what we're doing for his cardiovascular system. And then, so that's all under the category of the activity modification. The next is, I think, the one of the pinnacles is isometric loading in combination with collagen and vitamin C supplementation about 60 minutes prior to the actual loading. I'll talk about the references below. Additionally, we've incorporated not only in clinic but home blood flow restriction training multiple times per week for his accessories and quad and hamstring targeted exercises while still having him load heavy with slow duration and or isometrically with his primary lifts. Additionally, we've incorporated a patella strap. I'll speak to that and the rationale there. And then finally, we also are working on biomechanical movement retraining, trying to incorporate more of a hip and posterior chain strategy with his foundational movement patterns. Thus, we're in hopes of like offloading the knee, simultaneously also strengthening the posterior chain such that his quadriceps to hamstring ratio begins to normalize. Okay, so here is some of my rationale for the science behind what we're doing and why I believe the regimen will be successful and why it contrasts compared to the other 18 months worth of shockwave therapy, PRP, other rehab that this gentleman has had. So you can see in figure B, such as the dynamic jumping movement, where the stress concentrations in the tendon don't actually penetrate the injured location that needs the remodeling and the mechanical stimulus. However, with isometric holding over 10 seconds, you get a stress relaxation of the surrounding tissue. Thus, the mechanical stimulus penetrates the scarred tendon, allowing for epigenetic changes and the remodeling of the tendon. Specifically, we know that stress relaxation peaks at about 3 minutes at 55% of stress relaxation. However, 45% of that occurs, or 45% of stress relaxation mechanically occurs at 40 seconds. So we've used the 80-20 rule that we get 80% of the benefit by holding for 40 seconds with high intensity load, specifically of 70% MBIC. Here's a schematic to demonstrate what we're doing chronically. So we're feeding the tendon about 60 minutes before, we're loading the tendon, and we're getting the adaptation stimulus as shown here. Muscle adaptation will continue beyond this 0 to 10 minutes, but you'll see that the actual adaptation of the extracellular matrix within the tendon will be it really will the signal will be saturated after 15 minutes of loading. So this is strategic in our programming because we are loading immediately upon entering the gym, such that we don't saturate the extracellular matrix response to something such a stimulus that it would be isotonic or ballistic in nature. And we're also incorporating the collagen peptides against about 60 minutes before. We know that it takes at least 6 hours for that signal to be able to be sent again. So if we're going to do multiple bouts of isometrics, it needs to be separated by 6 hours. And so the regimen would be shown here. 6 hours between bouts, collagen peptides before, isometrics at 70% MBIC, doing 4 to 5 bouts of 40 seconds, such that we're not exceeding that saturation period. And then we're doing 2 minutes rest. We are not using NMES because he does not have an activation issue, but that could be a consideration for others. We know that within 3 to 4 weeks we can see positive remodeling, and then over subsequent years this has been shown to actually fill in a complete tendon rupture. Not that this is the case in this individual's situation, but it does speak to the potency of this protocol. Here's a specific example. It's taken out of Jeanfavre's work that using 15 grams of gelatin, again, hydrolyzed collagen has been shown to be just as effective. Really, the main signaling property here is proline, which is the amino acid. And what we can see is that collagen synthesis rate with gelatin and or hydrolyzed collagen actually has a twofold increase with a proper dosing 60 minutes before. So we're giving the body the remodeling process, the remodeling building blocks, and then giving it the mechanical signal such that the body will actually put the building blocks where they need to be. All right, so this next image is one that I think is quite profound and important for, in my opinion, this individual. So what you see on the left-hand side of the screen is a healthy tendon. What you see on the right-hand side of the screen is a pathological tendon. And when you look at these two tendons under histology, they look exactly the same. However, what you're seeing is epigenetic mapping of the tendons themselves. And so let's look at the pathological tendon for a moment. You can see that there's green at the base, that is the insertion where the bone is, and then you also can see that there's green expression of the epigenetics in the center of the tendon. So the significance of this is that these tendon cells are acting the same as those at the insertion, and this is because of the compression signaling, mechanical signaling that these cells are consistently getting. I.e., when we look back up at this, you can see that there's a compressive load here when the force circumvents the injured site, and thus there's compressive forces, and then these connective tissue, these non-differentiated yet connective tissues will then express collagen matrix that is comparable to that of the bone, leading to the pain in the persistent disability of the tendon. However, when we use isometrics, we no longer have compressive forces. We actually have the tensile forces that tendons actually respond to. Thus, we can further change the epigenetics of the tendon cell expression back to the what you would see in a viable tissue. And though this takes time, and so we've talked about at length the importance of patience with this. If you want to learn more about this, I've hyperlinked a couple of resources, specifically this YouTube by Dr. Jeanfavre, who has done some seminal work in this field and has really been influential in my understanding of how to construct protocols that are appropriate for the remodeling of and the changing of the epigenetic nature of the tendon. This next reference that I've hyperlinked here is the role of hyaluronic acid in sports-related tendinopathies. So one of the considerations before maybe surgical intervention, however, that's beyond my scope, is to determine indications for that. But my suggestion would be that the individual would trial some hyaluronase injection into the tendon. Specifically, what that would do, I have a model down here, so it actually would help specifically change a lot of the pathology that we see within the tendon itself. I guess more, this is a great reference shown here, but a simpler model would show this. that the injection of hyaluronic acid on the tendon cells. So it would be have several of the mechanisms by which tendinopathies occur, right, with vascular uh, neo, neovascularization is the and with like the stromal compartment, right? So we're getting a more natural form of collagen that would be consistent with that of the uh, tendon itself, rather than like the compressive bone that we're seeing, the neural compartment and the meunier compartment, et cetera. Without going too far into depth, but again, I've hyperlinked this article for further reference as needed. But I think that that would be, in my opinion, a consideration that would help to reduce the intratendinous pressure within the tendon such that it's not consistently epigenetically expressing bone, and this would only further help with the isometric regimen that we're currently implementing. The last component here that I had alluded to was the patella tendon strap. So this is no strap that you're looking at the patella tendon. You can see the insertion here. So very similar to the exact location where the patient has his condition. With the chapeau strap, what we can see, the Chopat or the Donjoy strap, is that it actually distributes the force more evenly. Thus, we're reducing the maximum amount of compression at that area. Thus, with the sole intent of having more of a uniform exposure of mechanical stimulus and loading to help to facilitate the remodeling of the tendon. If you're beyond, though I like the visual mapping as shown here, it gives the full picture. The actual significant and the data of the local strain percentages are shown below. So yeah, those are the big takeaways. If you're interested in knowing specifically what he's doing from a loading standpoint, I've shown it here. So it's a 2-week cycle that he's running for day 1 and day 2, and we have a hip dominant and a knee dominant day. This gets probably a little bit more beyond the scope, but you can see the example here. If you're interested, where this would be his warm up, where we're doing some type of higher cardio. What we have done is doing his isometrics. So we're taking this and we're implementing it prior to his warm up such that we're not getting a tendon saturation. We've got high volume, high intensity, slow duration sets. And we're also utilizing blood flow restriction training with these additional accessory movements. So yeah, that's kind of where he's at. He's strong, he's powerful. We need structural and cellular changes to the tendon for this individual to be successful. I believe that taking these steps and this plan of attack will be, I'm hopeful that he will be successful because it's different than anything that he's done thus far, according to him. And then the sixth one that I would put on there would be hyaluronase injection potentially as another consideration for reducing the tendon pressure. If we're really going to exhaust conservative management prior to any other more invasive treatments. But I hope this helps to convey where the gentleman is at. I'm optimistic, hesitantly optimistic. Again, I'm only new to his case. He's been through over almost 2 years of this, having missed his last sophomore season, and junior season is uh, already nearly upon us. But he's a very powerful athlete from a biomechanical standpoint. The numbers, again, as I mentioned at the beginning, are extremely impressive, especially given the disability and given his anthropometric size of height. And yeah, I think he'll be. I think he has some wonderful potential for to be a successful athlete, and I'm hopeful that we can really help him to fulfill that potential. All right, thanks for listening.